Alright, so in this lecture we're going to talk about the anatomy of the lungs. So the structure of the lungs, it's located in the thoracic cage on either side of the mediastinum, and the mediastinum, as we're going to talk about in a few lectures here, is this central portion of the thoracic cavity that contains the heart, the great vessels, several other structures, and so the lungs, right and left lungs sit on either side of that, and the inferior surface, so that would be, this surface down here and this surface down here. It's called the base of the lung, and it rests on the diaphragm, which the diaphragm is that dome-like muscle at the base of the thoracic cage. It goes up like this. The superior region, so this portion here and here, is called the apex. And the lungs are the site of exchange of O2 from inspired air. So if you have your lungs like this, air comes in, so O2 comes in. And then you have the pulmonary vessels coming in here, the pulmonary capillaries. The O2 is going to go in, and then the CO2, which came from tissues, because when if you remember from metabolism and biochemistry, metabolism gives off CO2 as a byproduct. So CO2 goes into the bloodstream, gets taken up to the pulmonary vessels. CO2 gets released out, breathed out, and then O2 gets breathed in, and then diffuses into the blood, and that provides our oxygen for the rest of the body. All right, so the lungs are each divided into lobes. The right lung has 3 lobes here. The left lung has 2, and the reason for that is that the structure of the heart, the heart is essentially rotated into the left lung, and that makes it smaller and divided only into 2 lobes. The right lung, it's divided into the upper, the middle, and the lower lobes. And it's separated by these fissures, which you can better see in this diagram. So this is your horizontal fissure. So here, because it's just a horizontal line, and then the oblique fissure is this line like this. So the horizontal fissure separates the upper lobe from the middle lobe, and then the oblique fissure, as you can see here, separates the middle lobe from the lower lobe. So the left lung, it's divided into the upper and lower lobes, so there's no middle lobe. So you have the upper lobe here, and then the lower lobe here, and there's only one fissure, which is the oblique fissure, which is right here. Each lobe in both lungs is supplied by a lobar bronchi branching from the main bronchus. So here you have your main, your trachea here, and then you have your main bronchi here. Okay, you can see that very nicely here. And then the main bronchi, they split into these lobar or segmental bronchi. So this one goes to the upper lobe, this one goes to the middle lobe, this one goes to the lower lobe. So lobar meaning they go to each lobe. And so then you have this main bronchus, which splits into this lobar bronchi on the left, which go into the upper lobe, and then this lobar bronchi go into the lower lobe. So there's 3 lobar bronchi in the right lung, 1 for each lobe, 2 in the left, again 1 for each lobe. So the blood supply of the lungs is sort of unique, mainly because of the job of the lungs being, providing oxygen and enabling to get rid of CO2. So the lungs receive a dual blood supply. And so what you have here is the main thing we all think of is the pulmonary artery, which this is where you can get tricked up. Arteries mean away from the heart. Okay, this is the, one of the exceptions where an artery is not carrying oxygenated blood. So away from heart, A and A. So it receives blood from the right ventricle. So the right ventricle is the pumping, the blood comes around, it goes into the right side of the heart, and then it gets pumped into the pulmonary circulation by the right ventricle. And we'll go over that in more detail in the heart lecture. And so as we said, the veins are carrying CO2-rich blood from the tissues, and the O2 has been used up by the tissues. So that's why we say the venous blood is, CO2-rich, O2 depleted, and it's going to the lungs to participate in gas exchange. And so the final leg of the venous blood traveling back to the lungs is that it travels through the pulmonary artery, and you can see that here in blue because it's CO2-rich, deoxygenated blood coming out in there. So you have the pulmonary artery or pulmonary trunk, and it splits into the left and right pulmonary arteries respectively that go to each lung. And the pulmonary capillaries are just adjacent to the respiratory region. So you have these, alveoli in the lungs in the respiratory tree that we talked about, and then you have the capillaries that come, just underneath, and this is where CO2 gets dumped off, and then O2 comes back in from air being breathed in. And that's this is what's called gas exchange. So then the pulmonary veins, which you can see here in red, so the veins carry blood to the heart. The pulmonary veins, they carry O2 rich blood because they, take the blood that has gone through gas exchange, meaning getting rid of CO2, picking up O2, and they bring it back to the left atrium. So the pulmonary veins are actually the most O2 rich vessels in the entire body, more than the aorta, more than any other artery, because they're the first vessels to receive the freshly oxygenated blood from the lungs. And then they carry it back to the left side of the heart. So the right side of the heart receives blood from the venous system and pumps it to the lungs for gas exchange. The left side of the heart receives oxygenated blood from the lungs and then pumps that oxygenated blood to the rest of the whole body, to the systemic circulation. So the other half of the dual blood supply is the bronchial arteries, and these branch directly off the aorta. And so these are, oxygenated blood. These are just like any other, like the renal artery or the common iliac artery or femoral artery, just like any other artery coming off the systemic circulation. So they carry blood, and these are what provide, blood supply or perfusion to the lung tissue itself. Pulmonary artery, I wouldn't think of it much as it's not responsible for perfusing the lungs. What the pulmonary artery and pulmonary vein are responsible for are bringing blood to the site of gas exchange and then bringing it away. They're unique in that their job is not to provide nutrients and oxygen to the lung tissue. So, and that being said, the bronchial arteries, they're quite the opposite. They don't participate in gas exchange at all. These are not involved in gas exchange at all. Their strict job is to provide perfusion to the lung tissue itself, because the lung tissue, just like any other tissue, needs oxygen to function as well. It needs nutrients to function as well. And so if it's not really getting it from the pulmonary artery, it's got to get it from somewhere else, so the bronchial arteries come in. So the bronchial arteries, they drain into the bronchial veins. The right bronchial vein drains into the azygous vein. The left bronchial vein drains into the left superior intercostal vein or the accessory hemiazygous vein. And we'll go over these veins in much more detail in the vessels of the thorax lecture. So as a result of this dual blood supply provided by the pulmonary artery and the bronchial arteries, clots that form in the pulmonary arterial system, meaning the pulmonary artery, the pulmonary trunk, or the right or left pulmonary artery, they actually do not cause ischemia of the lung because you have those bronchial arteries, which are the main perfusers. In a sense, you're more so blocking gas exchange or preventing blood from getting to gas exchange than you are preventing. It's not like blocking a coronary artery or blocking blood flow to the part of the heart. And so that's why, if you have a blockage or a pulmonary embolus, which is a blockage that would form in here or both, it's not like you have ischemia and necrosis in the lung, that because you have those bronchial arteries providing that collateral circulation. And in fact, what kills someone from a PE or pulmonary embolism is that you have a pulmonary, you have a large embolus in here, the one that would kill somebody that comes in here. What that causes is right heart strain, because, not to get too much into this, but if you have the heart like this, and like I said, it's divided into the right side, the left side. The right side is responsible for the pulmonary artery, so PA. If you have a blockage in here, the right heart has to squeeze against this, and it strains the right side of the heart, and what ends up happening is the right side of the heart goes into failure. And then as a result of that, the entire heart goes into failure and it strains out, and that's what kills somebody. So it's not like a heart attack where the lung tissue is deprived of perfusion. It's more so that you're straining the heart, and then the heart ends up giving out. So bronchopulmonary segments, these are anatomical, functional, and surgical subdivisions of the lung. So these are subdivisions within the lobe. So you have these, upper, middle, and lower lobe. You can see that here. You have the main bronchus, you have the lobar bronchi, and then you have the segmental bronchi, which you can see here and here and here. So these are each, segments of each of the lobes, as you can see here, and then you have, these and these and these. So, there's multiple segments within each lobe. And each of these bronchopulmonary segments, they consist of a segmental bronchus that we've pointed out here, which is a branch off the lobar bronchi, a segmental branch of the pulmonary artery. So here's a pulmonary artery, and remember, it's carrying deoxygenated blood, so that's why it looks blue here. These segmental branches of the pulmonary artery, they're carrying blood to each segment to receive gas exchange. and then the segment of tissue, of lung tissue within a lobe that is surrounded by a connective tissue septum. So if you have a lobe like this, you have these connective tissue septums like this, which would, this would be like S1, S2, S3, and so on, of the different segments. So segment 1, segment 2, segment 3 within each lobe, and they have these connective tissue septums that help separate them out. And they're called intersegmental septums. So each of these are it's like a section within each lobe. It's got a blood supply, it's got a special bronchus providing air, and it's got a vein that helps drain it. So it makes it very compartmentalized. So like I said, the pulmonary veins, they also have intersegmental and serve as surgical landmarks for each of the pulmonary segment. Now, what do these segments do? The reason we say they're surgical divisions is it makes it very convenient for a thoracic surgeon to selectively remove an affected lung tissue. Let's say you have a tumor in this, upper portion of the upper lobe, so this upper segment. So let's say you have a tumor like this. The surgeon could come in and just take out this section of the lung. And since this section of the lung has its own blood supply, its own air supply from one of the bronchi, what you do is you just tie off that blood vessel and that bronchi, and then it's just a blockage to airflow and blood, and instead of going through to that section because it's not there anymore, it just gets redistributed to the other segments and lobes of the lung. So you're not cutting off a major blood supply. All you're doing is cutting off, when you take this segment out of the affected lung, is you're taking out the feeding blood supply and the feeding bronchi, and then you're leaving the other bronchi and the other vessels supplying the other segments of this lobe and other lobes intact. And so it allows you, again, to selectively remove parts of the lung. And it helps you limit the amount of lung tissue removed. So since you have it up in the upper lobe here, you don't have to take out the entire lobe. You can just take out this affected segment and then leave the other segments of the upper lobe intact. Each lung has a hilum where the main bronchi, pulmonary arteries, pulmonary veins, and lymphatics communicate with it. So this is the right and left lung taken apart here. And this would be the medial surfaces shown in here, so on both sides. And this is really the main thing that, if you're doing a cadaver-based course, is the main thing you could get tagged. Is they love to tag these and make you figure out which one's the artery, which one's the bronchus. So the big thing to know here is that the right pulmonary artery enters the right lung anterior to the right main bronchus. So here's the pulmonary artery, here's the right main bronchus. So you can see this would be anterior, this is posterior. The pulmonary artery is entering in anterior to the right main bronchus. And then just to point it out here, here's the pulmonary veins here and here. The left pulmonary artery, so if we go down here, here's the bronchus as we have it indicated here, so this part right here. And then here's the pulmonary artery, which you can see here, and it's superior to the left main bronchus. And so that's one thing to point out there. And then you have the pulmonary veins, which are exiting here. So a good way to remember this is RALS is a helpful mnemonic. So right anterior, and then left superior. So right, the pulmonary artery travels anterior to the bronchus, and then on the left lung, the pulmonary artery travels superior to the bronchus. Lymphatic drainage of the lungs. This isn't super high yield. We'll just run through this very quickly. Lymphatic vessels, they like any other organ, there's lymphatic vessels in the lungs. They carry out excessive interstitial fluid. They travel to the bronchopulmonary nodes. Then they travel to the inferior and superior tracheobronchial nodes. These are nodes just around the tracheum and the bronchi. And then you have the tracheal nodes, which kind of run up here with the trachea in here. And then you have the bronchomediastinal nodes as well, which would be more down in this region near the mediastinum. And then the bronchomediastinal trunks, which then empty into, you have the right lymphatic duct here, then the thoracic duct. So these trunks would travel into these ones in here and here. And then the thoracic duct and the right lymphatic duct are what then empty into the systemic circulation into the subclavian veins. And we'll go over these ducts in much more detail in the Vessels of the Thorax lecture. So the lungs, just like any other organ, they receive visceral innervation from the autonomic nervous system, and their main conduit is the pulmonary plexus. So here it's labeled bronchial plexus, same thing, pulmonary plexus. It lies on the anterior and posterior surface of the roots of the lungs, so near the hilum. So the hilum is also an area where autonomic nerves will be coming in and out of the coming in and out of the lungs. So it helps. It also forms connections with the cardiac and esophageal plexus. So you see the cardiac plexus, esophageal plexus here as well. So it forms connections with these plexi as well. And since it's an autonomic plexus, it has sympathetic and parasympathetic fibers from the pulmonary plexus. They provide innervation to smooth muscles of the bronchial tree, glands of the bronchial tree, and the pulmonary circulation. So if you have a cross section here of of the bronchial tree, you know, you have smooth muscle tissue in here. Okay. And so that's your smooth muscle. And so that's what those, you know, contract and relax to, you know, control the diameter or the radius of the lumen, thus controlling how much airflow goes through each, you know, segment of the bronchial tree. And then there's also gland tissue in here. So gland tissue in here, and these, you know, secrete secretions into the lumen of the lung, and these, you know, play a role in asthma. In fact, a lot of asthma drugs will target these to help prevent secretions. And then the pulmonary circulation, which, just like any other circulatory area, you know, they're helping control blood flow to regions of the lung. So this is a nice table. It's in your book. It helps, again, like we've talked about, cell bodies, so important where they are. So the sympathetic T1 to T4 sections of the spinal cord, it's going to be the lateral or intermediate horn is where the cell bodies are going to be for the sympathetic division. And then the ventral root is where the presynaptic fibers will travel. Then they'll go through the white ramus and then synapse within the sympathetic trunk. Then after they synapse in the sympathetic trunk, they'll go through the thoracic visceral nerves, and that'll take them to, you know, the pulmonary plexi and then to the lungs. Big effect of the sympathetic nervous system is vasoconstriction, so decreasing blood flow, and then bronchodilation. So what does that? So if you have your bronchus like this, and you have, you know, your smooth muscle like this, so what they're going to do is turn off contraction, okay, of the smooth muscle. And what does that do? That allows it. That allows the lumen to get larger. Now, why would you want to have a larger lumen? If you have a larger radius or a larger lumen, more air can flow through it. You know, air is a fluid, just like, you know, blood. It's just a different consistency, and it's the same type of thing. You know, if you make the lumen of an artery wider, more blood flow is going to go through. Same thing with the lumen of the bronchial tree. If you make the lumen of a bronchial segment wider, more airflow can get through. Now, why does that make sense? If you remember, the sympathetic nervous system is the fight or flight response. So if the fight or flight, this is, you know, preparing you for heavy physical activity. Heavy physical activity, you're going to need a lot of oxygen, you know, to feed your brain, feed your muscles, so you can move and run away. And so, needing more oxygen, what do you need? You need more airflow to make it into your lungs. So more airflow means increased bronchodilation. Parasympathetic system. So these cell bodies, they're in the medulla or the brain, which is part of the brain stem. They travel through the vagus nerve, and then they synapse in the pulmonary plexuses, and then also, if you remember, like many parasympathetic fibers within the tissue wall of the bronchi and the pulmonary vasculature. And after they synapse, you just have these small. So if you have, you know, your target organ like this, you know, the fibers come in here, they synapse within the organ, and then you just have these short postsynaptic fibers within the walls of the bronchi and the vasculature. Now, what do these do? They do vasodilation, bronchoconstriction. So if you remember, parasympathetic is rest and digest. So you're more resting. You don't need a high metabolic rate. You don't need as much oxygen when you're resting. So you can afford to bronchoconstrict or make the lumen, you know, have these muscles constrict, which will give you, you know, a much smaller lumen, less airflow. You know, I mean, it's not going to totally constrict off, because that would mean you have no airflow, but it's going to give you, you know, much more, you know, limited airflow than you would need if you were in full physical activity. This is also bronchoconstriction is what also happens in asthma. So when someone has an asthma attack, their bronchial smooth muscle is contracting, and it's making the lumen much smaller. That's why they're gasping for air and you know, during an asthma attack. It also, parasympathetic, they stimulate mucus gland secretion. This is another thing that happens in asthma. So on top of having a narrower lumen, you also have more fluid and mucus that's getting secreted into here, which also limits airflow. Now, in a normal person, you can have parasympathetic stimulate mucus gland secretion, and that's a totally normal process. That's not going to kill you or make you short of breath or anything. It's just a normal physiological process that happens as a result of parasympathetic stimulation. And that concludes our discussion of the lung anatomy. In the next lecture, we're going to talk about the clinical pearls relevant for the lungs.